This is the Northridge Earthquake, 30 years later, a catalyst for engineering resilient communities webinar series with many organizations involved in making this happen. And that includes the American Society of Civil Engineers, Infrastructure Resilience Division, the ASCE Los Angeles section, the Earthquake Engineering Research Institute, Southern California chapter, of which all of the people that you see on your screen are on the board. Myself, Mark Benthian, the Statewide California Earthquake Center. I am the Secretary Treasurer. Craig Davis is a director on the board, and Marshall Liu is past president on the board. Also, the Structural Engineers Association of Southern California are a part of the partners of group here, as well as the Earthquake Country Alliance, which I lead, again, at the Statewide California Earthquake Center. Craig.
Okay, thank you. My name is Craig Davis. Mark just introduced me somewhat, and I will be the moderator for our speaker, Marshall Liu. But to get started, I want to point out that this is episode 6, and we've had, of course, 5 prior episodes of webinars that are available online. The first one was an introduction to the January 17th, 1994 earthquake, covering science and engineering aspects, 4 different speakers. Episode 2 was covered insurance issues and impacts following the Northridge earthquake. Next one, Mark. Episode 3 was 30 years of progress and quantification of seismic hazards. And episode 4 was an unexpected milestone in real-time loss estimation. Next slide. And our last one was episode 5, Legacies of the Northridge Earthquake and Disaster Recovery Planning and Policy. I'm not taking time to introduce all of the speakers. You could see those on the screen, and you can go to the Earthquake Country Alliance to identify those. They've all been excellent speakers, very professional and useful knowledge. If you haven't seen these already, I recommend you go back and take a look at those that you may be interested in. And now I'd like to move on to the formal introduction of our episode 6, titled The Northridge Earthquake, the Catalyst for Resilience of Healthcare in California. And our speaker is Dr. Marshall Liu, who has been and continues to be a geotechnical consultant, a former member of the California Hospital Building Safety Board, both in 1999 to 2006, and then from 2015 to 2023. So Marshall has been a practicing geotechnical engineer for over 47 years. He has worked on too many hospitals for me to mention, but it is in his bio. If we were to go to the link for this site, and you can see it if you haven't already. He's been active in new construction and hospital upgrades for seismic improvements to meet the SB 1953 requirements. And he's been involved in the development of regulations to carry out SB 1953, and has been involved in reviewing code changes and policy regarding hospital design and resiliency. He's a member of EERI since 1978, so a long-term member, and served as the Secretary-Treasurer of EERI from 2006 to 2012, and is selected as an honorary member of EERI in 2018. So with that, Marshall, I would like to hand this over to you to speak and remind the audience that we will have a Q&A session after he finishes his presentation. So as the Mark mentioned, as questions come to mind, please fill them out in the Q&A session, and we'll address those after Marshall finishes the talk. So Marshall, take it away.
I'm trying to share my screen. Okay.
We can see it, but it is not in presentation mode.
Here we go. Okay, does everybody see it now?
Yeah, it's perfect.
Okay, thank you very much, Craig. the title for my presentation today is The Catalyst for Resilience of Healthcare in California. And healthcare is something that's very important in this particular state. One of the problems that our healthcare system here has, as compared to a lot of other states in the union, is we are we're not a stranger to earthquakes, and we've had our share of them. They're going back to the great 1906 San Francisco earthquake. Here we see the ruins of St. Mary's Hospital in San Francisco. This was a hospital that had been built in the 1850s, I believe, and actually survived fairly well, had some structural damage, but got completely wiped out by the Great Fire that resulted from the earthquake. In 1925, there was the Santa Barbara earthquake. And this is the St. Francis Hospital in Santa Barbara. And you can see all the shear failures in this building, and probably looking at the crack patterns, you see it's probably of masonry construction. Backwards. Okay, 1933, there was the Long Beach earthquake, which is close to home here where I am. And you can see here, this is one portion of the earthquake, and the two photos that show about the same area. And up there on the third floor, you can see where the surgery rooms are. And this was a masonry construction also. Now, out of the 1933 earthquake, one of the legacies of that was the Field Act, which improved the design and building standards, but only for California schools. They do not apply to hospitals, even though, the same type of damage that was observed in the schools there, because a lot of them were on reinforced masonry buildings. They didn't extend it to hospitals. But it's sort of 1933 was also a year where building codes became more important and seismic design became a part of the regimen in California. Well, later on in 1971, we had the San Fernando earthquake. And here you can see the damage to the San Fernando Veterans Administration Hospital complex. 4 buildings had collapsed, and there were 47 deaths. The Olive View Medical Center in Sylmar had been open for 1 month, just 1 month. And you can see here the failures that occurred because of the soft first story, and also, non-ductile concrete design. It was a wonder that it didn't further collapse. You can see how precariously this building was leaning, some of its wings. Now, 12 years after the San Fernando earthquake, that's when the state finally acted with the Alquist Hospital Facility Seismic Safety Act of 1983. This was signed by the governor at the time. And then out of that, we got OSHPD. And for OSHPD, it became essentially the building department for all hospitals, and then preempted enforcement of building standards from all the local jurisdictions, which prior to that time, each city or county was responsible for overseeing the plans and construction of hospitals. So now it was centralized at the state, and then out of that, California Building Standards Code also had a separate really another version of the building code, which I think at the time was a uniform building code, which applied to hospitals, which included special requirements for hospitals. So that was enacted, and that only affected design and construction of new hospitals. Now, 1989, we had the Loma Prieta earthquake, and there was a study done that researchers had interviewed 51 hospital administrators and 49 out of the 51 emergency departments, nurses and physicians who were on duty at that time. Of course, all these were in the six counties that were affected by the Loma Prieta earthquake. Now, fortunately, the earthquake's epicenter, the Loma Prieta earthquake, was not in a heavily populated area. And so we did not have a lot of, say, major structural damage. But out of this questionnaire, it noted that, problems on all these interviews was a lack of communication within and among organizations. Hospitals received inadequate information about the disaster from local agencies. 43% of hospitals had inadequate backup power configurations. 5 hospitals sustained total backup generator failures. 20 hospitals had partial evacuations. And also, not really mentioned here, there was also a lot of non-structural damage. So Loma Prieta kind of put hospitals back into the public eye, but it was not that big a deal at that time. And a few years later, 5 years later, we had the Northridge earthquake. Now, this building here is the Kaiser Permanente Medical Office Building in Granada Hills, and which is somewhat, if you look at a lot of publications, it's kind of like the poster child for that earthquake. Now, it was a medical office building. It's not a hospital, not under OSHPD jurisdiction. But I have a funny story about this one. About 2 years prior to the earthquake, I was a geotechnical consultant helping Brandau and Johnston work out some plans to seismically retrofit this building because it was recognized it had a soft story problem, and it also had non-ductile concrete frame, so a lot of poor detailing. And then came the earthquake, and here's the result. We had the second floor collapsed. Now, that morning, when I saw the pictures of this, I had a panic. Only later I found out, they were planning to start the retrofit work in March of 1994. So although the building was a loss, professionally, I was kind of afraid that we had done something and it didn't work. So anyway, that's why this building has special meaning to me. But it is a kind of a grim reminder of the hazards that we have still even today in some of our non-ductile concrete buildings. Now, remember the Olive View Medical Center? It was replaced by a new hospital. It was replaced with a hospital that had not concrete shear walls, but steel shear walls. So big steel plates were used. I think it was designed by Nabi Youssef. And the building did great structurally. However, you can see there, say the first picture to the right of the caption, you can see an area that's a work area. You can see all the ceiling is a mess. The lights were in disarray. Some had fallen. There were other problems. You can see to the bottom, the picture at the bottom there in the middle, you can see that there was MEP equipment on, probably, I think this was probably an air conditioning unit. And you can see that it separated some of the connections to the building at the roof. And then upper right, this is at one of those upper penthouses that you see in the photo on bottom left. You can see the light fixture that was attached above door 9. And that's the light fixture sitting on the ground that fell off during the earthquake. Problem when you use steel shear walls is it became a very, very stiff building. So if you're looking at a response spectrum, you're in the area domain where you have very, very high accelerations. So forces were very great there. And so I think practically every elevator was out of service in this building. And it had to be, I believe this building had to be partially evacuated at least, because all the elevators were out of service. And there was a lot of other damage. I think there was water damage, other type of things that part of the non-structural infrastructure had a lot of problems. So this pointed out a shortcoming in the design of new hospitals. Another discovery out of this earthquake was in the welded steel moment resisting frame buildings. Now, you probably, those of you that in that day, you probably remember all the talk about steel beams that were welded to the columns that they had separated or they had cracked or they had the welds de-welded. And here, Holy Cross is one of these buildings, and Holy Cross did an inspection of all the joints in the building's frame, and they examined about half the building and half the joints. They found 35 cracks in the steel support beams. I guess it was the hospital, and I guess their structural consultants said that at that time it didn't pose an immediate danger to patients or staff. So Holy Cross ended up tearing this building down and replacing it with a new building. How about some good news from the Northridge earthquake? Here's the USC University Hospital, as it was called at that time. Now it's part of the Keck Medical Center, the Keck Hospital. This is over at in the area near East LA, not far from the LA County General. This was base isolated building, and the building went through fine structurally, and also did not have any major non-structural damage. Building was functional. See down here, they had lead rubber bearing that was at the foundation level. Not really a true test for this building in terms of the ground motions at this site. A nearby ground motion station put in by the California Strong Motion Instrumentation Program recorded a maximum ground acceleration of 0.25 G. So not as strong as the ground motions in the epicenter region. Now, over at St. John's Hospital in Santa Monica, I believe this is probably built in the late 30s or well, it could have been in the 30s or 40s. Reinforced concrete building, but you can see here all the shear cracks here. really this ended up causing this building to be taken out of service and totally evacuated. It was replaced by a new hospital building with elastomeric seismic isolation system similar to the one at USC. Now, regarding resiliency of healthcare, look at what happened to St. John's statistics in terms of patient days and patient discharge. Here in 1994, you can see that their patient days dropped tremendously from where they were in previous years. 92, they had like 75,000 patient days. They dropped off to less than somewhere around 13,000 patient days in a reduced facility. And look at the patient discharges. And you can see that after the earthquake, took a few years before they could, took a few years to rebuild the hospital in this time frame to build a new one. And now they've kind of returned back. So this is a problem when you lose facilities like hospitals, is you also lose their function. Now, out of the Northridge earthquake came solutions to some of the problems, like the dog bone connection for steel construction, because a lot of failures were occurring where these beams, where the horizontal beams would be welded to the columns, the vertical columns, and the columns would, had all kinds of failures, weld failures, or actually you might have a failure of the web here or web here. It might even be delamination of the weld. And these were the things that initiated the SEC steel moment frame study, which came up with various recommendations. And this dog bone was one of those, as a way to forces the yielding to occur in this reduced section of the beam so it can sustain the large inelastic strains and acts as a fuse, limiting the stresses in the less ductile region near the face of the column. Also, other solutions, including buckling restrained brace frames. And here, the braces absorb the energy from the cyclic loading, avoiding increasing the stresses in the region where you have your beams and columns, beam column connections. And then also came in applications of viscous dampers, and that's to provide energy dissipation and also limit the displacements. So these are velocity sensitive and not displacement sensitive. And in addition, there are other types of energy dissipation devices used. Now, on the heels of the Northridge earthquake, remember that after the Loma Prieta earthquake, there was no legislation introduced. In the month following the Northridge earthquake, just a little bit more than a month, Senate Bill 1953 in that year was introduced on February 25th by Alfred E. Alquist and signed into law on September 21st and became law on September 22nd. And out of that, the provisions here amended the Hospital Safety Act of 1953 with provisions that required provisions and regulation to be added to the building codes to address the survivability of non-structural and structural components of hospitals after a seismic event. So the ultimate benefit, safety benefit of the Act is to have general acute care facilities that are not only capable of remaining structurally intact, but also capable of continued operation and provision of acute care medical services after a seismic event. That the non-structural damage was really pointed out in 1994. And this was, having a building that survives doesn't necessarily mean you'll have a business that survives. So this was the major action, SB 1953, and it kind of started something new. Now, all hospitals were required to file reports. It took quite a few years to implement all the regulations and then the procedures to implement the Alquist Act. Now, the structural performance categories were to be assigned by two buildings, and the evaluations were to be made such that you can determine what the risk of collapse to a strong earthquake. Now, I have a very sensitive mouse here. Get back. The SPC ratings range from 1 to 5, and 1 to assign risk to buildings that collapse to a strong earthquake, and SPC 5 assigned to buildings reasonably capable of providing services to the public following a strong earthquake. And the state law required that all SPC buildings had to be removed from providing general acute care services by January 1st, 2020, unless an approved extension had been granted. And all SPC 2 buildings would be removed by 2030. And so structurally, all compliant buildings, if they wanted to continue operating past 2030, had to be either SPC 3, 4, 4D, or 5. Now, what are these categories? SPC 1 was a category where these buildings pose significant risk of collapse and danger to the public. So these had to be brought up to SPC 2 level as a minimum by January 1st, 2008, or be removed from acute care service. The exception was buildings with an approved extension were permitted to provide acute care up to an extended date, which was January 1st, 2020. So reports had to be submitted by structural engineers attesting to the SPC levels. SPC 2, these buildings do not significantly jeopardize life, but they may not be repairable or functional following a strong ground motion. Okay, so this was just life safety level. And these could stay in service until 2030. SPC 3, these buildings may experience structural damage, which does not significantly jeopardize life, but they may not be repairable or functional following strong ground motion. These buildings are compliant with the original Alquist Act in 1992. And these are the ones that are utilizing steel moment frames and constructed under a permit issued after or prior to October 25th, 1994. So these were approved by OSHPD prior to October 25th, 1994. Because these buildings in this category would have been constructed or reconstructed under an OSHPD building permit. These buildings can be used to 2030 and beyond, but notice that they may not be repairable or functional following a strong ground motion. SPC 4, these buildings are compliant with the structural provisions of the Hospital Safety Act, but may experience structural damage, which may inhibit the ability to provide services following strong ground motion. These have been constructed under OSHPD permit. Or OSHPD, HCAI, I'm going to use them kind of interchangeably. OSHPD used to be part of the Department of Health Services. Then the state a few years ago established a new department, which is called HCAI, which stands for Healthcare Access and Information. So that's a separate department, and OSHPD has been moved into that department. SBC 4D, structural performance category that was introduced in 2019, which allows non-compliant buildings to go past the 2030 deadline. And then it's recognized retrofitting SBC 1 and SBC 2 buildings to the highest standard. SBC 5 would essentially require existing buildings to meet existing code. This is either prohibitively expensive or impossible for almost all buildings. Rather than requiring these to retrofit fully to SBC 5, they could be retrofitted to a level called SBC 4D. So it's a structural standard that's equivalent, similar or comparable to SBC 4 buildings, which are already approved to provide acute care services beyond 2030. It was a voluntary program and primarily used to help those with SBC 2 buildings. And that retrofit work has to be completed by 2030 to allow for acute care services to remain in service beyond 2030. SBC 5 is buildings in compliance with the structural provisions of the Act. These can be used 2030 and beyond without restriction. Now, non-structural performance categories where things get tricky. All general acute care hospitals are assigned a non-performance category, which measures the probable seismic performance of building contents, equipment, systems, and critical to patient care. So this is non-structural elements, equipment, including cladding, partitions, ceilings, equipment, pipes, conduits, ducting, furnishings, contents, elevators, stairs, as well as water, sewage, met gas, and other mechanical and electrical systems. The ratings go from 1 to 5, 1 being where equipment and systems critical to patient health care, which would be completely non-functional following a strong earthquake, and NPC 5 assigned to those which are reasonably capable of providing services to the public, having all these non-structural performance of these particular elements work well enough. Okay, NPC 1, buildings that don't meet any of the requirements of other NPC ratings. NPC 2, in order to have that, you have to have systems that communication systems, emergency power supply, bulk med gas systems, fire alarms, emergency lighting and signs, means of egress have to be met to be qualified to be NPC 2. To reach the NPC 3 level, you have to meet all the requirements of NPC 2, and in critical care facilities, you have to meet the bracing and anchorage requirements that are in Part 2, Title 24. Not going to go through all of this, but basically, you got to go up this ladder. You can't go to NPC 5 in one step. You have to make sure that you meet all the requirements. NPC 4, the building meets all the requirements for NPC 3, which is all the interior stuff. And then now your architectural, mechanical, electrical systems, components and equipment, and hospital equipment meet bracing and anchorage requirements of Title 24. So that's NPC 4. NPC 5 requires you to meet NPC 4, and then you must have on-site supplies of water and holding tanks for sewage, liquid waste, sufficient to support 72 hours emergency operations, and are integrated into the building plumbing system in accordance with the California Plumbing Code, and on-site emergency systems been defined in that electrical code. Additionally, systems shall provide for radiological service and a non-site fuel supply for 72 hours of acute care. Now, the NPC system is a cumulative system. It's one where you have to meet each of these. You cannot go to 5 automatically by doing one thing. You have to meet 1, 2. You go from 1 if you're down at 1. Then you have to meet 2. You have to meet, to get to 3, you have to meet the requirements of 2. To get to 4, meet the requirements of 3. To get to 5, meet the requirements of 4. So currently now, what's the status of hospital compliance? HCAI and OSHPD on their website, and I've given you here the web address, gives you the most current data for any facility as to where they stand in terms of their SPC and NPC ratings. Now, I've chosen a hospital here. This is the Kaiser Foundation Hospital. This is the one I go to. This is where I spent time in April after going to emergency and having to spend the night. This is the Kaiser Sunset. Here you can see they have 4 buildings on the list here. One is the Centrex building. And this is the requirements for it. Currently is an SPC 4 and NPC 2. Has not gone up the ladder yet. The main medical building, the one that was building was completed in 2014. It has an NPC 5 report submitted, has not been reviewed. Well, it has been reviewed, but right now it is rated as an SPC 5, NPC 4. The central plant at Kaiser Sunset is an SPC 5, NPC 4. And then there's a non-structural, not a building. There are some tunnels, and really doesn't have an SPC. It's not applicable to it. Has an NPC level 4. So you can look up any hospital you want in this on this website, and it lists every building. So, you know, there's, I think of, thousands of buildings, and you can find out the status, most current status. And this is, I downloaded this in early October. Now, this is where we started. 2001. This was the stat here. You can see this pie chart. 39.1% of all hospital buildings were SPC 1. These were not deemed to be safe, really. And it's out of a total of 2,627 buildings in acute care buildings in the state. SPC 2 was only 7.6%. SPC 3, 12.7%. Buildings that, and these were primarily steel frame buildings that had been reviewed by OSHPD prior to October 1994. SPC 4, 27.6%, and only 13% met the SPC 5 category. SPC 5, those are reviewed by OSHPD, and since I think it was the enactment of the act of the Alquist Act, so they were rated as 5s. Here's the status as of October 4th, 2024. SPC 1s, we still have 41 buildings, 1.2% that are in the SPC 1 category. A lot of these hospital buildings are in regions or areas that have really underserved communities, and they've gotten special dispensation under different legislations to allow them to continue operating despite their ratings. Because if they had to be taken out of service, there wouldn't be any health care available in those communities. SPC 2, we still have 19.9% in that category. SPC 3, 11.7%. SPC 4 or 4D, 23.9%. And I'd stop moving my mouse. SPC 5, 43.2%. Now, in terms of compliance, you can see the SPC 1 and SPC 2 combination there is about 21.1%. All the conforming buildings, these are the buildings that are conforming at this time. SPC 3, 4, 4D, or 5 on the structural level, 78.8% are in compliance. So, you know, we have until 2030 to meet this. So goal now is to move those SPC 2s buildings. Either they're going to have to be taken out of service or replaced with new facilities, and some of them will be. SPC 1s, those are a little bit harder. Okay, here's the NPC non-structural performance categories. In 2001, when survey was made, or in 2000, there were 2,000 buildings. 73.8% were NPC 1s. Almost a lot of people had non-structural problems. NPC 2, only 15.2% met that requirement. NPC 3, 1.8%. NPC 4D, I think, was just being implemented, and so it's 0. And NPC 5 was this is and something's wrong here. Well, anyway, a lot of buildings in 2000 did not do very well on the non-structural side. Okay, this is where we are in 2024, October 24th. No buildings are NPC 1s anymore. Everything's been at least upgraded to a minimum of NPC 2, but almost half the hospitals in California are just at the NPC 2 level. NPC 3, 7%. NPC 4 and 4D were about 36%. Those buildings meeting NPC 5, 6.4%. So, still got a ways to go on this. The non-structural is lagging, and still all these have to meet the 2030 deadline. So that's where the program stands as of today. And upcoming soon, a lot of you in the state, we go in California, you go into a restaurant, there's a rating on the food, a rating of that restaurant, A, B, C, or fail or something. Well, you're going to see a sign like this in the hospital telling you about the structural integrity with the SPC levels and the NPC levels. And this is going to be required to be posted in each acute care building in California to inform the public about the structural and non-structural conditions. Hospital owners are very thrilled about this. Okay, here's the latest update. This year, SB 1432 was introduced by Caballero, and he wanted to amend the existing act of 1983 to allow extensions to 2035. And here it would authorize hospital owner or operator to submit an application by specified dates to the department for additional extensions to the compliance deadline. This bill would require the department to grant or deny an extension of the deadline for substantial compliance with structural safety regulations and standards up to 2035. We require an application to contain a seismic compliance plan, a specified evaluation report, financial plan, and attestation to the department and appropriate governing board of that hospital is aware that the building is required to be in substantial compliance with the act. However, even though this was approved by the State Assembly and Senate in August, the governor vetoed this act on September 12th, 2024. The bill has been returned to Senate for further consideration or resubmittal, and that's the latest updates. So that's where we are in California today. So being a member on the seismic safety, hospital seismic safety board, I've seen the program develop, had some part in developing some of the requirements and reviewing some of the regulations that went into it. And I think that SB 1953 has proven itself to be a successful program in the development of seismic safety and resilient healthcare communities in California. We're a lot better than we used to be. We still have a way to, I think we're well on the way structurally. Non-structural work needs to step it up, but we're going to get there. So I'd like to thank Chris Tokus, Director of HCAI, for support and encouragement, and to Doctors Roy Lobo and Hussein Bhatia of HCAI for providing the latest data on SB 1953 compliance. So with that, I thank you very much. And back to Craig.
Okay, thank you, Marshall. That was extremely interesting. I found that very fruitful to watch. And we have a few questions. So let me start with one. A friend of yours, normally I won't mention names, but I am going to this time. Ranaguchi says, thank you, Marshall, for a very informative talk. Were there any surprises that you saw after the Northridge earthquake that affected the performance of critical facilities like hospitals? And if so, have we effectively addressed the issues?
Well, I think, what I personally saw, I went out after the earthquake and I looked at a lot of hospitals since I had, at that time, Kaiser as a client, and saw damage at the various hospitals. Fortunately, Kaiser's hospitals did fairly well, but there was a major failures in some of the parking structures there. But I think in terms of a hospital observation, the most telling one was my visit to Olive View, to the new Olive View Medical Center, to actually walk through the floors and go into the building and up to the roof and see all the non-structural damage of what was essentially, a battleship of a building. I mean, it was totally disrupted on the inside. Record rooms, all the records were off the racks. Now everything's electronic, but equipment was scattered. Even though it was a structural success, it was a non-structural disaster.
Yeah, that was interesting. So I guess important, since you bring it up here, that we need to better address those things, and hopefully they're being addressed as you move along. We have another question that I'm going to ask you here. For those in the audience, feel free to ask your questions on the Q&A button. So here's another question for you, Marshall. Why is it difficult for acute care facilities to meet the NPC, the non-structural performance category requirements, as compared to the SPC requirements?
As it turns out, in terms of when you construct a new hospital, you're actually spending much more money on the non-structural things that make a hospital work than the structure itself. It's not like your house, which may have cost you $5 million, and then you spend $100,000 in furnishings or $250,000 in furnishings. A hospital has, you got to put in all that infrastructure, MEP, communications, all sorts of backup systems. These all cost money. Now, and then, in trying to work in an existing building to try to do these retrofits is very costly because you got to work within the confines of an existing building and try to minimize the disruption. Otherwise, you might lose, say, functionality, or you lose space, and there's going to be a lot of disruption. And so it's costing a lot of money. And a lot of hospitals and, big systems might be able to afford it. Of course, they all complain. I remember listening to people, HCA, Healthcare Association, saying that, this is an unfunded mandate. You're forcing us to spend all this money. And that's why a lot of these hospitals now, especially the ones that are, say, not doing as well financially, they're hard pressed to come up with the money to make these changes and to do this work.
That's an interesting outcome that maybe wasn't foreseen, which leads me, I'll just throw in a quick question here. It leads me to something that I've been wondering, and I hear things about, but I don't know how valid it is. Were there any hospitals that just said, I can't meet this and went out of business?
There have been quite a few hospitals that have closed, gone out of business for whatever reason. And, there's been a lot of mergers of some healthcare systems where they've consolidated facilities.
That's an interesting outcome because that affects us on a daily basis as compared to waiting for a big earthquake. One more question and then we're going to wrap it up, at least formally. So Marshall, this is a two-part question, so maybe try to take it quickly since we're at the end of time. For a very small percentage of the SPC1 category structures that are still remain in service, was anything done to somehow enhance those structural conditions? And the second part is, since the Northridge earthquake, was there an increase in base isolated buildings?
All right, first question. We don't have any idea what's been done, and those maybe they might have mitigated some, but they haven't mitigated all of those. A lot of those hospitals are the ones that are in the more depressed areas. Probably why maybe they haven't met those requirements. And what was the second question again?
Are there more base isolated buildings?
Yeah, there was immediately after the earthquake, say maybe the following 5-6 years, there was an increase in the number of base isolated buildings at hospitals. I worked on a few of them. St. John's was one of them. Hoag Hospital had another. VA, not under HOSPA jurisdiction, did a retrofit base isolation of the Veterans Hospital in Long Beach. There were some other hospitals recently. I think the Stanford Medical Center, base isolated. Here in Southern California, Loma Prieta and the Loma Linda Medical Center is base isolated, and that's a massive building. And also there's another one out there in Colton. There's another base isolated hospital. So, base isolation is there, but a lot of hospitals are still using, say, more traditional technologies.
Okay, thank you, Marshall. I'm going to step in here and formally wrap up this webinar by letting you know that our episode 7 will be in a few weeks. It's titled Lessons Learned About Business Losses and Economic Recovery, the Northridge Earthquake as a Catalyst for Research and Application. You can register online and at this link, and we'll be sending out notifications in coming days and weeks as well. The presenters will be Professor Emeritus from University of Colorado Boulder, Kathleen Tierney, who did some excellent studies after the Northridge earthquake on the businesses, and Dr. Cynthia Kroll, who's a regional economist in the Bay Area, who has used some of the results of those studies in more recent work. And so Ann Wine will be our moderator in my place. And I also want to point out that Marshall, myself, and Mark are able to stay on for a few more minutes if some people want to stay on and have further conversation. But for sake of and respect of people's time, we're going to formally wrap up this particular webinar. And so we thank you for attending and look forward to our future episodes, next one being episode 7 on November 13th. So Marshall, there is actually another question that came in.
Yeah.
So let me throw that out there and we'll just continue with the conversation. So those that want to stay on, feel free. We can see who's here. And we'll stay on until about a quarter after if the conversation is intended to carry on naturally. So the question is, I'm just going to read this off the cuff. Marshall, I haven't read it yet. So we are in Burbank, California. How do we know if a building we are renting is already for the safety you have mentioned? Although this is not a hospital, but most offices here are healthcare or in the healthcare industry. I'm sorry. You could also read that, Marshall, if you go.
Yeah, I'm reading it now.
Question.
Yeah.
So I
Yeah,
broke that up. But
yeah, the act only covers acute care facilities, which means hospital facilities, and acute care means overnight stays. If you're in a building that had like medical offices, it would not be under OSHPA jurisdiction. Or even a separate medical office building that might be operated by whatever hospital. Cedars-Sinai has their hospital, but they also have clinics that are not overnight. They're medical office buildings. And, if you needed to overnight stay, they would transfer you to the hospital. So you would not find your building listed in that. Sorry.
All right. Well, thank you for the answer. We don't have any other questions, but there are some people who apparently are still on unless they just walked away. You can also raise your hand, and Mark can actually allow you in this period of time. We'll just allow a conversation if we want to actually talk to Marshall, Mark, or myself. Just raise your hand, push the raise hand button, and Mark can allow you to stay on. But in the meantime, Marshall, I have a number of thoughts. I work more so in the lifelines field as well as geotech with you. And the non-structural stuff seems to be quite applicable to a number of lifeline industry type buildings. And I'm wondering if there's a way that we might consider utilizing what has already been developed there and trying to apply it or modify it to be used in the lifeline infrastructure system category, like to a water or wastewater treatment plant, as an example for the non-structural. Any thoughts on that?
Yeah, I hadn't thought about it, but certainly I think there could be some application because, it's you're not talking about one piece of equipment. They have to be they, some of these systems are, especially with all the, things now going, since we're going to AI, I'm sure that's going to affect all of our lives. Uh, we, the infrastructure is very important to keep the system going. And some of the things that support that infrastructure are going to be these non-structural type of elements.
Mm-hmm.
We're not just talking about pipes in the ground. Say if you're talking about telecommunications, are these facilities hardened enough to do it? Probably the phone companies are smart enough, but I don't know.
Yeah, well, maybe something we can explore. But we do have another question that came through the chat from Eric. I'm not sure I spelled it right. I apologize if I didn't. It says, what do you think is the reason that base isolation is not gaining popularity in the US, at least on a greater level?
Well, I think base isolation is coming back a little bit more now, but in terms, it may take a little bit more time. The analysis is a little maybe more intense, but I think probably some of the testing requirements may have been a hindrance in the past because you had different size isolators, but now I think with more recently, since there have been a lot more base isolation applications, say for a certain type and size of isolator, they have the prior test data, which can be used to verify its capacity and what it can do and what it can't do. So, recently I think we're beginning to see some increase in the number of base isolated hospitals. So, I think we might see some increase, but a lot of places, very tight schedules. They know what they want, and they're kind of married to a certain type of structure, particularly some of the health systems.
Thank you, Marshall. We do not currently have any hands raised or typed in questions. So if anybody online wants to do that, feel free to raise your hand or type in a question. And I'll just kind of leave this open free to Marshall to say anything that comes to mind that he knows he was unable to put. And actually, there is one more question. I forgot. So which hospitals are having the most difficulty meeting the 2030 performance standards of SB 1953?
Yeah, I think I mentioned it earlier. It's those hospitals that are generally in the underserved communities, rural hospitals, or in poor urban areas. And these tend to be small hospitals. So they don't have a large financial base and they're not part of a system. So those are the ones that are having the biggest problems.
It kind of makes sense. You could follow the logic there. So Marshall, if you have any other thoughts that you want to share to our dwindling audience, I would say this would be a good time to do that. And then when you're done with that, we'll wrap it up unless somebody in the meantime raises their hand or types in a question.
No, I'm just thank everybody for their attention and putting up with an old guy talking about hospitals.
Well, great. Thank you for sharing your knowledge. This has been great. I've known you for, I don't know, a couple of decades now, but I hadn't seen this part of your career come out before. So I found this very interesting, especially for a longtime professional geotechnical engineer who's trained as a structural engineer out of UCLA. You have quite a vast array of things to share with people. So we really appreciate that. And it's coming out in this presentation. So
Thank you, Craig.
there's a hand raised. There is one hand raised. I'm not sure. Oh, Eric, the same guy who asked a question before. Mark, if you could allow that person to speak.
Yeah, just go ahead and unmute. We should be able to hear you now.
Okay, thank you. Can you hear me?
Yes.
Yeah.
Yes.
Thank you very much for the opportunity. It was very nice presentation. I enjoyed it. Throughout my career, I did work with you. You may not remember me, but anyway, thank you again. My last question, I don't want to abuse your time, but my last question is, can you briefly mention anything related to any novae materials that probably are used in the hospital construction? I know there are some new materials that have been developed and are still developing. Are there any construction or work done with new novae materials?
Yeah. I don't, with my connections with the Hospital Safety Board, I know that whenever anything new is being proposed, they want to see test data and things that support how good the material is going to be and things like that. But I'm not aware of that. That's something that that would be handled by Oshpod Structural, and I'm not aware of that.
Okay.
Thank you. Thank you.
Yeah. Thank you, Marshall.
Yeah.
For sake of Marshall's time, he needed to be done by right now so that he can move on to his next activity. So we want to respect his time since he put in all this effort on our behalf. So I'm going to formally wrap up the informal portion of the discussion. So we're going to close now. And again, we thank you all for your interest and time.